and welcome. It's 8 p.m. UK time, so it is time to start our live event once again. And we do have another special guest, and Dr. Raul Olivares is back with us. So, hello, Dr. Raul. I hope you are
Hello.
good, and I'm very, very happy and excited to have you back as our presenter. How are you feeling tonight?
Well, excited. I mean, we are going to talk about many different topics. So let's see if I can make an interesting webinar for the attendance.
I have no doubt it's going to be interesting, of course, no doubt here in whatsoever. So, already, I would like to thank you for joining our Stronger Together initiative. Once again, this is our second edition, and it's really, really good to have you back on board with us as well. And of course, we will start with Dr. Raoul's presentation on good embryos and poor outcomes, what to do. So, as he's mentioned, he will talk a bit of a few things here. So, stay tuned, of course. And afterwards, as always, it will be your time for your questions. So you can prepare them. You can write those right now or later on. And Dr. Olivares, I'm sure, will be happy to answer all of them for you. And before we start with the presentation, as always, I want to mention and thank our ambassadors and partners. They have been supporting us from the very, very beginning. We started this initiative in March, and we are going strong. And we have more and more events for you prepared. So I just want to say thank you from whole IVF Media team for their support. And well, that is it. Right now, I guess we can go ahead with the presentation. And as I mentioned, just remember it is going to be recorded. But of course, right now, if you have questions during the presentation or later on, you can just go ahead and do it. And well, Dr. Raoul, are you ready to begin?
Okay. Thank you,
Perfect.
Caroline. Good night. Good night, everybody. Here we are again. This webinar is going to be slightly different. I mean, rather than get deep into some specific issues, I prefer to cover a lot of issues and then discuss which is the evidence that we have about their usefulness, no, and see if we can really recommend or we must advise against them, or if we still don't know which if they are going to help us in these cases in which we are transferring good embryos and that the success does not arrive. So, as always, the first thing that we have in these cases is when we look into the internet, the first thing is that we should avoid losing our head, gathering information. And as I always say, we are quite of a fashion victims because there are such a huge amount of information available there that is very easy to get impressed by any article or a study with a few participants that is not going to provide us with a really reliable information. So stay calm, talk with your doctor. You have to ask about any information rather than thinking that what you read on the web is going to be an absolute truth. The first thing that we have to do in these cases is try to find what an implantation failure is, and that's the main problem. Probably not the main, but the first problem is that doctors, we don't even agree about when we can consider that there is an implantation failure. Okay, because and this also makes very difficult to compare the different studies, because there are studies in which they have transferred 4 embryos, and other they have gone through 2 different IVF through rounds of IVF. In others, it's like 2 blastoses. So it's very difficult. I would say that the first thing that you must be aware is the kind of staff we're working with, and the embryos is under in general, and the reproduction, human reproduction, is far from being efficient. It's very, very inefficient. And as you can see, when we compare all these cases, the implantation failure is probably 30% of the cases that we have. Then there are biochemical pregnancies, clinical miscarriages, and only 25% of the embryos that we can create are going to become babies. So this give us an idea of how inefficient the reproduction is. Of course, these implantation failures can be due to problems with the embryo, mostly genetic issues. As you see, this is a result of a pre-implantational genetic screening, or they can be due to endometrium or body or environmental problems in the woman. So, I think that the first thing that we have to understand is that if we see these different graphics, we see this is the American registry. We see the live birth in the left one in red, and we see that as we get over 40, the live birth is very low. And this is exactly the opposite that happens with regards to the genetic issues in the embryos and the miscarriages. You can see the live birth is very similar to this other graphic in which we are checking the successful implantation, and the miscarriages are very similar to this other one in which in blue, where we can check the aneuploidy, which are the genetic issues. So it's going to be very different to study an implantation failure when the patient is 29, and we know that most of the embryos are going to be genetically normal, that when the patient is 42, because in this case probably more than 90% of the implantation failures are going to be due to abnormalities inside of the embryos. So how we can define the implantation failure? I would say that when we talk about young people in our clinic, once we have transferred two good embryos, and also the good embryo is a concept that it could be difficult to define. But for example, when the patient is younger than 35, when we are doing egg donation, once we have transferred two blastocysts and we have not got a pregnancy, we may start studying or requesting for or asking for tests to see if we can find out the problem. When the patients are over 40, then we transferring more good embryos in terms of morphology is not enough. We need to be sure that we are transferring embryos that are genetically normal. You can see this is a single PGS of a 41 years old woman in which we tested 19 embryos in a single cycle, and only two were suitable for being transferred. All the others were abnormal. So you should expect to have a lot of genetic issues in the embryos. And before starting considering endometrium biopsies, blood tests, immunology, and things like that, we first must be sure that the embryos that we are transferring are of good quality. Therefore, once we transfer good embryos and the patients don't get pregnant, what are the kind of things that we can do? The first thing is obviously confirm that there are no anatomic issues that may interfere with the implantation, like having septums in the cavity, having hydrosalpinx or things like that that may also reduce the implantation rates, fibroids, polyps, or even a chronic symptomatic endometritis that you can see in the hysteroscopy. All these kind of things are treatable. We can reshape the cavity, we can remove the hydrosalpinx, we can remove the fibroids, we can give antibiotics and get rid of this chronic inflammation and create a better environment for the patients. Okay, so that would be obviously the first step in all cases. With regards to the implantation, the first thing that I have to say is this is what we see, and this is the reality. So we are still far of knowing what's hidden in the implantation. There are more than probably 300 substances involved in the implantation, creating or influencing if the embryo is going to get deep enough, if it's going to successfully interact with endometrium. We are barely we barely know how some of them work, but we are still far from knowing how real implantation works. So these are the things that I'm going to talk today. We are going to start talking about recurrent implantation failure, and we are going to consider this all these things that has been suggested to improve the implantation, the scratching, the hysteroscopy, checking for thrombophilia and antiphospholipid syndrome, the role of the vitamin D, smoking, immunology, those tests that are supposed to validate the different things in the endometrium, like window of implantation or microbiome, chronic endometritis, obesity, and TCH. And I'm going to explain how do we work in our clinic based on the evidence that I'm going to show you. The first thing is that something that is very clear is that obesity reduces the receptivity, the uterine receptivity, and patients who are have a really huge or big or high BMIs have poorer implantation rates. Okay, probably the problem is related to the hyperestrogenic state that patient who are overweighted has, but the results in, and these are studies made on egg donation, so the quality of the embryos, the quality of the eggs is somehow guarantee the theoretical impact of the embryo in these outcomes, poor outcomes, was supposed to be low. And these big studies with 22,000, almost 10,000 studies confirm that if your BMI is high, the implantation is going to be lower. So the first step, especially in cases of egg donation, is try to reduce the weight of a patient with BMIs over I would say over 30, and probably and for sure over 35, because the implantation rates are going to be much higher. And the evidence that we have is strong, is of a good quality, and that's something that should be taken into account. The same happens with smoking. I mean, the studies, the meta-analysis, the big studies of Whalen, and this study carried out in an egg donation cycles show that when you smoke, the receptivity of the endometrium is going to be lower. Um, the problem with the smoking is that it's not something that if you give up the next day you are going to be completely safe, or you're going to completely solve the problems. There is kind of a stuck in effect on the on the with the smoking, and you may need more time to get to eliminate these side effects. But the sooner you stop, the better the outcome is going to be, and this is something that has been confirmed in pregnancy. I mean, if you stop smoking at the beginning of the pregnancy, the risk of complications in the last 3 months is going to be much lower. And the same happens in reproduction. It's probably better if you give up smoking 2 3 years before considering getting pregnant. But even if you are in a treatment and you stop smoking, in a few months you're going to get the benefit of that. Hysteroscopy has been a first step treatment during many years. Unfortunately, this study, which was published in 2016, so it's quite recent, it is a wonderful study. It's a multicentric, randomized, different countries, a lot of people involved, show that hysteroscopy, when there's nothing wrong in the scan, in a normal scan, does not help at all to increase the live birth. And remember that the only thing that we want when we do an IVF is a baby. We don't want eggs, we don't want embryos, we don't want positive, we just want babies. So whenever we test any of the different tools that we have, we must know if these tests are going to increase the live birth rate. This study involved 700 patients with several numbers of failed IVF that hadn't had a hysteroscopy in the previous 2 months, and there was a kind of an algorithm to balance the different characteristics of the two groups, so they were very similar. The results that you can see here show that the risk ratio of between the hysteroscopy group and the control group were exactly the same. So when the scans were normal, hysteroscopy were absolutely inefficient in terms of increase in live birth. Even in this subgroup, because there was a small group in which during the hysteroscopy they were able to identify things that were not easy to identify in the scan. The scan was supposed to be normal, and then what they did is that they treated these patients in which they were, small polyps, stenosis of the cervix, hemiuterus, very light uterine abnormalities, and they compared the results. And even in this subgroup of patients that had these minor abnormalities, the outcomes were very similar. So, under my point of view, there is no reason to recommend a hysteroscopy in an implantation failure if the scan is completely normal. And basically, this is what this slide shows. This rhombus that you say here is just in the middle, because the different clinics, from Italy, from Czech Republic, from London, from Belgium, showed exactly the same results. That in no case, in no one of the clinics, the results were better after performing the hysteroscopy. The scratching has been one of the most controversial issues, because it's a very old history. This is probably, this study published in 2003 was the first one that suggested that doing the scratching could increase the implantation rate, but it was very well known from 40 years ago, that when the endometrium biopsy was a very frequent test, that people there was a group of people that after the endometrium biopsy got pregnant naturally, while they were waiting to start the treatments. So the idea that doing something in the endometrium could improve the receptivity has always been there. The thing is that this initial study, unfortunately, there are a lot of systematic reviews that have not been able to confirm that. Though in this one, there is a slight benefit that favors the injury. This meta-analysis, this study, was very, very criticized because the different studies were very, very different, depending on when they were doing the scratching, how often, and things like that. So it was really tough to compare the studies. More recent studies suggested, like this one, which is a randomized control trial, that there are no differences at all. And even in some cases, there is a trend towards having an adverse effect. Okay, the scratching is supposed to increase receptivity because the embryos need some degree of inflammation when they are trying to implant. And in a subgroup of patients, it could happen that this inflammation is lower than expected. So by doing the scratching, we are activating certain genes that have a pro-inflammatory state, and this helps the embryo implanting. But if we just do this scratching and the patient has not that problem, and the problem is that we cannot identify the patients that have a low inflammatory status, we are creating a hyperinflammatory state that may status that may also create a poorer implantation rate. So the equilibrium in the inflammation is very difficult to assess. In fact, we don't have any single test to check it. So using this is controversial. As I've said, it looks to trigger an inflammatory response, though the exact mechanism is yet unknown. It seems useless or even worsens the outcomes in patients with a clear recurrent implantation failure, because there are people that thought, okay, if this helps people to increase the implantation rate, why don't we do it to all the patients? And the results were even worse, as he said. So it should be done in very specific cases, probably when we don't know what else we can do. And if you want to do it, it must be done in the implantatory phase of the previous cycle. Okay, but it's very controversial, and according to this recent study, it should not be recommended, and if we have something else to do. Using of the heparin, aspirin, and things like that. Well, I know that there are many, many, many clinics that from the very beginning, they just give aspirin and heparin. Well, it's okay, but I really think that is completely unnecessary. First, because the evidence of all these studies from 2003, 2012, and 2018, so it's something that has been really constant, is that using heparin compared to placebo or using an IVF does not help at all. It does not increase the live birth. And I'm talking about regular IVF. and all these clinics that recommend from the very beginning just to try to cover as many issues as possible. It's true that there are certain conditions like thrombophilias and antiphospholipid syndrome in which they may help. We know that this kind of problems increases the miscarriage rate, and these miscarriages take place because there are local thrombotic problems when the embryo is trying to implant. So we kind of extrapolated that if the problem was at the implantation, there could be other cases in which this thrombosis may also prevent the implantation for taking place, and that given heparin and given or given aspirin may help to in this subgroup of implantation failure may help. Well, I'm sorry. That's it. I must say that we do that, but we only use heparin and aspirin when we think that there is an implantation failure. We don't recommend using it in all IVFs like many clinics and many protocols do, because the evidence is that they are useless. When there is a thrombophilia, when there is an antiphospholipid syndrome, yes, they make sense. Probably not because we are going to increase the implantation, but we are going to reduce the risk of miscarriage, and we are also going to reduce the risk of having complications during the pregnancy. But in a pure IVF or an implantation failure, it's also controversial. The ERA, the endometrial receptivity analysis, it sounded very promising. It's a test in which we have done a lot of research as well. Basically, is a test that it is done to see if the window of implantation is open. The window of implantation it's open by the progesterone, not by the dose, but when you start the progesterone. This window of implantation is a period of 2-3 days during which the embryo is allowed to implant in the endometrium. And based on some studies that check a number of genes that are activated, this test was developed in order to know if when we are transferring the embryos, the endometrium is receptive or not. The first thing that I must say about this test is that it is only useful in cases in which you are using an hormone replacement therapy, because the conditions should be very strict to repeat or to get a useful how would I say that, to make it useful. Okay, we have to do exactly the same cycle, and then once we have repeated exactly the same is when it makes sense. So it is useless for IVFs, it is useless for natural cycles, because in these cases every cycle is going to be different, only in cases in which you use hormones. The idea is to do a biopsy when the embryo is supposed to, or when the embryo transfer is going to take place, and then depending on which genes are activated and which genes are suppressed, they tell you if the window is pre-receptive, receptive, and post-receptive. My experience is not very good, and unfortunately, they have this group has already published this big study, 5 years of experience, and the only thing, with a lot of people involved from different countries, and the only data that they have seemingly improved by doing this, because they are now recommending that in all cycles of IVF the embryo should be frozen, and then the patient must undergo this test to exactly work out the window of implantation, and then transfer frozen embryos with this personalized treatment. This is what they are recommending, and I think that they are completely wrong, because if you see, the only data that really increases is cumulative live birth after 12 months. So you must invest 1 year of transfers to detect any significant benefit. So it's something that they would just recommend in cases of patients who are doing cryotransfers or egg donation. And of course, I wouldn't recommend at all to go to this kind of freeze all IVF, because the benefits are so tiny that the cost involved on doing these kind of things, and the cost of the test as well, which is not really easy because it's close to 700 euros or something like that. I think that is not worth the effort. and these are results published by them. So I'm afraid that the ERA is still far from being so as useful as they claim it is. This is also the test that I'm more confident. The test to check if there is any kind of dysbiosis or chronic endometritis. It has been designed by the same group than the ERA, and they all can be done in a single biopsy. But my experience with this test is much better. It's basically a test in which you do an endometrium biopsy on the day of the theoretical embryo transfer, and then you check if the bacteria, that the microbiota, the normal bacteria that should be in the endometrium, is the correct one, and if there is any kind of bacteria present at that level. And then, if in the endometrium, there should be more than 90% of lactobacilli. So this result was completely abnormal, with just a 0% and an active infection of caused by Streptococcus. And I have to say that we get rid of that infection, and in the first transfer after solving this problem, the patient got pregnant. And the cases, this is a quite new test. They have been around for probably not more than 2 years, so we are still gathering information. But they have proved to be very useful in some cases of patients that I really thought that they should have got pregnant and they didn't. And after fixing this issue, we managed to have an ongoing pregnancy. The idea is that they do the biopsy, and then if there is any infection, they just give antibiotics to get rid of that infection. And if there is a dysbiosis, so the percentage of normal cells is abnormal, then you use vaginal probiotic suppositories. And with this combination of antibiotics followed by vaginal probiotics, sometimes in the first attempt, sometimes after 2 or 3 attempts, because it's not so easy to eliminate this problem. Sometimes we create a really healthy environment in the endometrium, and it is much easier for the embryos. Probably the main problem is that these chronic endometritis are causing this hyperinflammatory status that damages the on one side the bacteria may damage the embryo, but also the embryo may find very hard to implant because of this high pro-inflammatory or hyperinflammatory status. So Emma and Alice sounds like a really good test, very promising in the future to explain some cases of implantation failure. Vitamin D is another thing that is really controversial. This is the first study that suggested that in 2010 that it could affect endometrial receptivity. It was a study in which there was not a very big study, not many people, and since then there have been a lot of people trying to confirm if the vitamin D was important for the oocytes, for the receptivity. What is clear is that vitamin D is important for the pregnancy, and we know that patients that got pregnant with low levels of vitamin D are going to have more complication in the last 3 months of pregnancy in terms of eclampsia, intrauterine growth retardation, and things like that. So, regardless of what I'm going to explain, vitamin D should be tested, and vitamin should be treated. The vitamin D deficiencies, not because we are going to improve the implantation rates, but because we are going to reduce the obstetric risk of the patients. This is another study carried out by a Spanish group testing the vitamin D levels in donors and 162, and they found no differences at all between the groups of low levels and high levels. So seems pretty clear that the vitamin D deficiency does not affect the quality of the eggs. And this is quite interesting because these are two big studies. As you can see, one was published in 2014, and the other study exactly in the same magazine, in the one in the number in the issue 101, and the next one in the 102. So in the next issue, checking the vitamin levels on in vitro fertilization outcomes. And you know what? The results are absolutely different. This study suggests that vitamin D is relevant, and the other says that it does not affect at all. So you can see how controversial things. This is the first study, the study carried out by Ruddick with 35 and 38 people, and all the results were significant. Vitamin D deficient, which is levels below 20, had poorer, significantly poorer clinical pregnancy rates and live birth rate. And the next month, this other group published this study in egg donation recipients, and you can see this green line is means that it's like tossing a coin, 50%. So it has no significance, and you see the results are that when you are dealing with vitamin D, you have 50% chances of having a problem or not. So basically, they concluded that it was not relevant at all. Okay, two big studies published in two consecutive issues of the same magazine, concluding completely different things. And there is this last study, which also confirmed that the vitamin D does not affect. In this case, they were transferring blastocysts genetically normal, so embryos of very good quality, and the impact was zero. Vitamin D did not affect it at all the outcomes. So, with regards to vitamin D, there are many factors that may interfere with the results. When it is done, which type of vitamin D are you checking, seasonality, ethnics, vitamin D in black people is completely different from Caucasian, from Asian. The technique used to assess the levels, it is still unknown at what level causes the problem, oocytes, endometrium, but it looks like transferring good embryos, donated oocytes, euploid blastocysts mitigates the impact of the deficit. So there is no current strong evidence of its usefulness, at least if the embryos are of very good quality. It could make sense if you're transferring 41 years old embryos and you just try to make things as smooth as possible to avoid any problems with implantation. But if you are doing egg donation, or if you're doing or you're transferring genetically normal embryos, the impact is very, very, very low. But as I've said, patients should still have normal levels because it's relationship with obstetric issues like preeclampsia of intrauterine growth retardation. So should be tested and fixed if it's possible. Immunology. Well, that's enough for a single big webinar. I'm just going to be very brief, but the first thing that I must say is that most of the classical knowledge about immunology comes from this study published in 1953. So now it's like 70 years ago. And it was based on three theories: the attenuated antigenicity of the embryo, so that the embryo was not really expressing genes that can trigger a reaction in the mother, that the placenta was a really physical barrier between the immune systems of fetus and mother, and that there was kind of a maternal immunological suppression. These were the three pillars of this theory, and all three have been destroyed, let's say like that, because we know that the trophoblastic cells of the embryos express histocompatibility antigens. These histocompatibility are those antigens that, for example, trigger the graft reaction. So these are the antigens that make the compatibility of the transplants very difficult, and why you have to take immunosuppressors. So the embryos do not have an attenuated antigenicity. They really expressing these problems. There is a cellular exchange between mother and the fetus. This is very well known. There are tests that allow us to get blood from the mother, and we can extract the DNA of the fetus and check if it's genetically normal or not. And the maternal immunity recognizes and responds to embryo antigen. So there is no suppression. The maternal immunity reacts against the embryo. So the three pillars of the theory are now abandoned, and they have proved to be wrong. And we are still doing research and tests based on this information. And probably the most common test is with all the tests that all the things that are done to check the natural killer levels. Okay, and of course, the first thing I must say is that natural killers in blood have nothing to do with the natural killers of the uterus. So all the tests that are based on checking or assessing levels of natural killers in blood are useless. They have the same name, but are completely different cells. Natural killers in blood are cytotoxics, and they help us to get rid of viruses, control cancer cells. They are really cytotoxics. Natural killers in the uterus, they have very low cytotoxicity, and they are this toxicity is triggered in very specific circumstances. They need to be activated by the key receptors in the mother. So what I've said before, there is an interaction between mother and embryo. They help the placentation because they induce vessel generation. So they are very important because they control deepness and pattern of placentation. So people must have natural killer in the uterus, and the levels around the implantation are very high. So all the tests based to trying to say that you have the high natural killers, that are completely useless, completely out of date tests, and especially if they check blood natural killers. So what happens when there are immunological problems? That people are given immunotherapy, which is, in my opinion, another big mistake. First, because with regards to the prednisone, and this is the American Society for Reproductive Medicine guidelines, okay? So that's what they recommend. As you can see, with regards to the steroids, there is good evidence to recommend against the routine use of corticoids during stimulation. And I see that there are still a lot of clinics that use prednisone, prednisolone from the very beginning, from the first step. No, as I've said before, the embryo needs some degree of inflammation. If we give immunosuppressive drugs like this in all cycles, we may be reducing the inflammation at the level of the endometrium, making it more difficult for the embryo to implant. So please don't use steroids if in general IVF is not going to help and is going to make things more difficult for you. With regards to the intralipids and the immunoglobulins, there is insufficient evidence to routinely recommend these kind of treatments. Only in very specific conditions of immunological disease, okay, but not based on natural killers, not based on Th1, Th2 ratios. No, these kind of things of tests are useless. So just restrict them to very specific conditions, and it's better if you don't use them because the evidence is very lack, or the evidence is against the routine use of these drugs. And why? Basically because they just focus on treating natural killers, and there are other cells involved in the implantation: T cells, endothelial cells, macrophages, dendritic cells, natural killers. And when you use immunosuppressive drugs, you are not just affecting the natural killers, you are affecting all these cells. So the implantation works like as an orchestra, is a very coordinated process. And if you start disbalancing natural killers, dendritic, you may end up with a bunch of kids making really a very hateful noise. So as we always say, first, do not harm. And using steroids in these cases is probably harming a lot of people. So according to this study published 2 years ago, the role of immunotherapy in vitro fertilization and in specifically in recurrent pregnancy loss, immunotherapy should be used in the context of research and should not be used in routine clinical practice to improve reproductive outcomes. Okay, and this is exactly what I believe. This is a study that was carried out in London, and the conclusion is very, it's based on all the systematic review of many studies, and I think this is a really good article. TCH, thyroid. Okay, so we have changed a bit the approach. This first study in 2010 uh, suggested that the TSH between 2.5 and 5 could increase the first trimester pregnancy, especially first trimester the miscarriages. Then there is a second one published in 2015 in which that was not very so clear, and they were transferring good embryos, so the TSH didn't seem to be so important. And now there are new recent studies that has suggested that TSH is only relevant when there is a clinical hypothyroidism. This is when levels are over 4, 4.2, 4.4, 4.4, depending on the laboratory results. But these are just one study recently published, so we are still controversial. The main problem with thyroxine is that really very important in the early stages of pregnancy. The thyroxine is an anabolic hormone, so it basically very important when there is a lot of cell activity, and you can imagine how many cell divisions take place in an embryo in the early stages. So when the patients are in these levels between 2.55, this may be enough to lead a normal life if you are not trying to conceive. But what happens if you conceive and the TSH is so close to the cutoff point? It may happen that these normal levels may not be enough to support the pregnancy. This is why when the TSH are above 2.5, it may make sense to send the patients to the endocrinologist to assess the overall state of the status of these patients, and then individually decide if it's worth giving thyroxine or not. If the endocrinologist says, okay, it is not necessary, then it's going to be very easy. You just wait until you're pregnant, and as soon as you're pregnant, you check again your TSH, and it has rises the levels, and you see that you can become hypothyroidistic. Uh, you can have this kind of subclinical hypothyroidism, and then it's better to start the treatment. And both approaches work pretty well. So what I do, or what we do, is that we send the patients to the endocrinologist, and then the endocrinologist decide if it's necessary or not. So this could be the summary of the different topics I've been talking about. We know those in red. It's something that I should not recommend. The hysteroscopy is not going to be bad, but it's going to be useless in terms of increasing your live birth. So it's an invasive procedure that in some cases could be really expensive, and it's not going to help you. In a recurrent implantation failure, you better have a really good scan, 3D scan, and if it comes out normal, forget about hysteroscopy. Immunology, very controversial. The treatments are not free of side effects. They are really expensive. The evidence is very, very low, and there are some of them that should be avoided unless there is a very specific condition that makes or immunological disease or something like that. A test like natural killers, Th1, Th2 ratios, CD 138, and things like that, in my opinion, useless. No, no, not helpful at all. And the only thing that we can do in these scenarios is make things worse, but we are not going to really help. Those that are in yellow are controversial. The scratching, well, it could be useful in some cases. I would recommend it only when we don't have anything else, and well, it can be done, and it could help. It could help, but at least in cases of recurrent implantation failure, it seems that it does not make it worse. But you should avoid it when there is no as a systematic procedure in all cycles or normal IVF. Thrombophilia, antiphospholipid syndrome. I would avoid using heparin and aspirin as a routine treatment in all IVFs. The evidence shows that they don't increase the live birth, but in specific cases of thrombophilias or antiphospholipid syndrome, it may make sense because it's going to reduce the risk of miscarriage, and they could help to make things easier for the embryo to implant. Vitamin D, again, controversial. Probably it could be useful to correct and fix it and focus on it when you are not going to transfer good embryos. But if you are working in egg donation, or you are transferring euploid embryos, it is not going to have any critical impact in the outcome. However, as I've said, it should be fixed when you are trying to get pregnant, because it has been clearly demonstrated that it may increase the obstetric risk. TSH, the same. Just let the endocrinologist decide. In any case, taking a bit of thyroxine is never going to be an issue. And but if not, you can wait until you're pregnant and then check again the levels. And if they are high, then treat it. Smoking, obesity, these are factors that have proved to reduce implantation. So try to have the best BMI that you can. In cases in which patients are 41 and have a huge BMI, our current approach is to do the IVF, freeze the embryos. So by doing that, time is no more an issue. You have your embryos frozen, but then we recommend patients to lose weight before we transfer these embryos. And smoking the same. It could also affect the ovarian reserve, smoking, but it's always better to quit smoking before you're trying to get pregnant. And the sooner you do it, the better the results are going to be. And the last one is the endometrial, which is the name of the test that includes the ERA, the EMMA, and the ALICE. And you see that it's half yellow, half green. Why? Because in my opinion, the ERA is still very controversial. Even that big study that the group has published makes that shows that the benefits are very light, and you must invest a lot of time to get a benefit. So only in certain cases in which you only can work with hormones, because our current approach when we are doing an egg donation using an hormone replacement treatment and the patient does not get pregnant is to, if it's possible, to work with the natural cycle, and then it's not necessary to do the ERA. But if the patient is menopausal or the cycles are very irregular and you must work with hormones, you must work with estrogens and progesterone, then it may make sense to do the ERA to check if there is a displacement of this window of implantation. But I'm really confident on my experience in the cases I've had with EMMA analysis is quite nice, and I've got several cases. It's very limited experience, but I would suggest that microbiota has proved to be very relevant in many other specialties like gastroenterology, pneumology, and also in gynecology, because we know that the microbiota of the vagina is very important in cases of recurrent candidas and things like that. So we are now improving our knowledge in the endometrium, and I'm pretty sure that they are going to become very, very useful tools in the future. And that's it. I know that it has been a very hard presentation with many topics. I hope that I've managed to give you a glance of each of the cases and why do we recommend them and why we don't recommend them. So if you have questions, I'm ready to answer them.
And amazing as always. Thank you so much. It's been definitely lots of details that you have provided, and that means that we also have many questions actually. So as you can see, and there's quite a big list of those questions. So I guess let's get to them straight away, right? Okay.
Mhm.
Let's have a look at the very first question that we have right here. So, when doing frozen embryo transfer with downregulation, is it an issue to find a dominant follicle at the baseline scan? Lining is nice and thin at 3 millimeters.
No. I mean, down regulation is nice, and in some cases we recommend it because usually when you are doing an embryo frozen embryo transfer, what patients do is that they undergo a treatment with oral estrogen to build up the endometrium, and once they have the right thickness, then we start the progesterone, and on day 5 of progesterone we do the embryo transfer. But in cases, for example, of adenomyosis, which is levels of endometriosis in the muscle of the uterus, having a strong down regulation could be nice. We don't work as a standard procedure with down regulation because the doses of estrogens that we use are enough to avoid any dominant follicle. But if you have any having a dominant follicle at the baseline scan, well, if you really have a dominant follicle and you've taken the down regulation, you just have to wait until the follicle disappears, vanishes, and then you can start preparing the endometrium. If you have that dominant follicle in the first scan because the down regulation has not been fully effective, well, you can add the progesterone, and then probably you would have to schedule the frozen embryo transfer sooner than expected. But as long as the patient has not ovulated, as long as the progesterone levels are not high, there is no issue with that. You can just move forward and carry out the embryo transfer.
And wonderful. Thank you so much for that very first question. And next question is in regards to BMI. Okay, there are like two, three questions very similar.
Hmm.
So let me just show them straight away. So is a BMI of 27 okay for fertility? And also, what is the healthiest BMI for someone going through IVF?
It should be under 25. I mean, that's the ideal. We know that the normal BMI is between 18 and 25, and if you have a lower BMI, you may have ovulatory disorders. If your BMI is over 25, you may start having problems again of anovulatory hyperestrogenism. However, I would say that if you are below 30, the impact of the BMI is not going to be that high. Once you are over 35, it becomes a problem. Once you are over 40, we do not treat patients. We recommend them going through a diet or going through surgery to reduce the BMI. So under 25, ideally, between 25 and 30 is not such an issue. And there are two nice studies carried out in Sweden and in Netherlands that showed that patients with BMIs between 25 and 30 that went on a diet for 6 months and lose between 4 and 7 kilos, I think, if I'm not wrong, they show the same pregnancy rates. So the main problem with BMI is how do you manage it? Because if you are 30 years old and you have a BMI of 33, probably it's better to invest some time to lose weight and then go with the IVF. But if you are 42 or 41 and your BMI is 35, you cannot invest 6 months losing weight because probably what you are going to lose, do you remember those graphics and how fast they reduce the live birth once you are over 40? This time that you are going to invest is going to probably lead to a worse outcome. So in these cases, since BMI seemingly affects receptivity, it is better to undergo the IVF, but then freeze the embryos, lose weight, and then transfer them. Okay, but that's age is the main issue. This is something that I've repeated in so many webinars. So the approach, it depends a lot on how old the patient is. But if it's possible, keep the BMI below 25, and if it is not really possible, under 30.
Wonderful. Again, thank you so much for that explanation. And again, there are like two questions on ERA test. You have mentioned that in your
Mm.
presentation, but anything you can add, would an ERA test help? And also, there is another one. Just give me a second. I had it right here, so I will show you in a second, okay?
Sure. But as I've said,
Sorry. Oh, yeah, sorry, right
yeah,
here.
yeah.
Due to having a chemical pregnancy, would you still recommend an ERA?
Well, the company claims that it's useful, and probably some chemical pregnancies may be due to an abnormal implantation. And this abnormal implantation, can it be done due to the fact that the embryo cannot get deep enough into the endometrium because it's not fully receptive? Well, the theory is that yes, it could be. But so far, the evidence, I mean, I think that the problem has more to do with the tool than not with the theory. I mean, the window of implantation is clear. My only concern is that I don't feel that the ERA is an efficient tool to really work out if the implantation window of implantation is open or displaced. Okay, that's my issue with the test. So as I've said, I would recommend ERA only in cases in which the natural cycle cannot be done because the patient is either menopausal or has very irregular cycles. Okay, because you have to do exactly the same that you've done when you have done the ERA. You have to do exactly the same. You have to kind of mirror the cycle to be effective. But if you work in the natural cycle, all the ERA tests that I've done in natural cycles were receptive. Was absolutely the window of implantation was normal. So why do you have to go through an expensive and invasive test if we can switch and work with the natural cycle, less hormones, yes, more scans because you have to monitor the follicle and trigger the ovulation, but on that's all. So only in cases in which a hormone replacement therapy cannot be avoided.
And again, thank you so much for the yet another explanation to that particular topic. And let's have a look at the next question. So, how often do you see hydrosalpinx flow through my tube cyst delight, which I know from a laparoscopy, and I have endometriosis?
Hmm.
Should I further investigate it?
Well, hydrosalping is another issue because the current knowledge is that you only must treat hydrosalping if you see it on a scan. If you do hysterosalpingography and you see that you have the lack of spill of the stuff into the peritoneum, but you do a scan and you see everything normal, it is not necessary to remove the hydrosalping. If you do a scan and you see something wrong at the tubes, it's better to stop to remove it surgically, or either by putting a clip or maybe by removing the tubes, because it is accepted that hydrosalping reduces the implantation rates, either because this fluid may go back to the cavity and be toxic for the embryo, and also because this liquid is a very inflammatory liquid that may also increase the inflammation at the endometrium, making it more difficult for the embryo to implant. So whenever you see a hydrosalping in a scan, don't go ahead with transfers. Remove it and then treat it. If you only see it on a hysterosalpingography, but you can't see it on the scan, I wouldn't recommend removing it at the very beginning. Probably I would go for some embryo transfers. But if the patient does not get pregnant, I would still consider removing the hydrosalpinx.
Again, thank you so much for yet another answer to this question. And of course, there is a question now that is a bit longer. It will be like in three parts, okay? I want you to
Hmm.
see the whole story. So here it is. I have one 16-year-old had a natural ectopic after my second IVF phase cycle, had 5 fresh transfers, 1 frozen embryo transfer, and transferred 9 embryos in total and only ever had a chemical pregnancy. I am just preparing for another frozen embryo transfer. Would you consider any test? I have had HCG, hysteroscopy, I have endometriosis and low AMH. I am preparing for frozen embryo transfer. I have been taking aspirin for 2 weeks, but my consultant says to stop aspirin 5 days before transfer as it is affects implantation. I've only heard of taking it through and not stopping. Not sure what to do.
Okay, so here there are two different things. One thing is that you've had an ectopic pregnancy. If you've had an ectopic pregnancy, this could have been due to any kind of inflammation or problem that was affecting the tubes. So if you have an inflammation, this could have been created by a chronic inflammation. And once more, we have the ALICE test, the endometrium biopsy, to check if the environment in the endometrium is okay or not. However, and once more, if there is anything I can please suggest is that whenever it's possible, give us your age, because this case is completely different. I mean, you have a 16 years old. I don't know how old are you, but it would be a completely different approach if you are 42 than if you are 36. Okay, thank you. That's great. Perfect. Then, of course, well, as I've said, you may have a problem with the embryos, or you may have a problem with your body, with the receptivity, or that you are 35. So initially, the idea that the embryos can have the problem is not really relevant. So what I would suggest in your case, because of the ectopic pregnancy, and the fact that because this basically demonstrates that your tubes have some kind of problem, is do a biopsy to see if the ALICE and the EMMA are okay, just to check your microbiota and discard any chronic symptomatic endometritis, despite having a normal hysteroscopy, because the hysteroscopy is very subjective when you want to diagnose this. That's one thing. Second one, well, I don't know if all your transfer embryos had been using hormones, using estrogens, and using progesterone. If you've been through these kind of cycles, another option could be switching to a natural cycle, okay, and using your natural cycle. Let the endometrium prepare with the natural hormones and see what happens. You just have to follow what's natural. Well, it's just one, but it was a good thing. So that makes sense. I would recommend to, if you have natural cycles, to keep working like that. With regards to the aspirin, on top that it could be useless if there is no implantation failure. The main problem is that it's usually um, recommended in the wrong way. The aspirin needs 3 to 4 weeks before the embryo transfer to have a full anticoagulant effect. If you start it at the beginning of the treatment, if you start it when you are doing the embryo transfer, or if you start it once you have the positive pregnancy test, it's going to be useless. You need to start in the previous cycle and at least 1 month, 3 weeks, 1 month ago before the embryo transfer. And of course, you should not stop it during the treatment. First, because if you stop it 5 days before the embryo transfer, it's not going to it's not going to be effective, because the effect of the aspirin lasts for 1 month if you have been taking it properly. In fact, when patients are going to deliver, they stop the aspirin 1 month before the due date to avoid any hemorrhage. So if you stop it 5 days before, I can't see the point. It's not going to have any impact. I mean, it's better to continue it in any case, because you are seeking for that anticoagulation. Probably before giving you aspirin, what I would have done is checking the thrombophilias, the antiphospholipid syndrome, to see if there is anything that really deserves to be treated with heparin or aspirin. But I would focus more on Alice, Emma, uh, keep taking a natural cycle and checking thrombophilias and aspirin. You must look for something that has changed. You were successful 16 years ago. Now you are not. The only thing that could have changed is this kind of inflammation that has damaged the tubes and that has caused a ectopic pregnancy. Try to see if this is also affecting the endometrium.
And amazing. Thank you so much once again for that. And I'm just checking. Of course, there is a thank you from the patient for you. But also,
You're welcome.
I saw there was another question. So I guess let's go straight to that one, okay? From the very same patient. So just give me a second. Okay, right here. Can you use the vaginal probiotic suppository, sorry, without having the EMA analysis test? And when should you start? How long and what brand is recommended?
Yes, in fact, this was the classical approach before we had the EMA analysis. In some cases, but before that, the only thing that we could do was doing an endometrium biopsy and carrying out an endometrium culture, not a histopathologic or an atomopathologic study. It was just to carry out an endometrium culture, and if the culture was positive, we treated the patients, and then we gave them vaginal probiotics, which was the problem, that most of the bacteria that the ALICE detects do not grow in the standard cultures mediums. So the endometrium biopsy to carry out a culture is not as efficient as the ALICE, because the ALICE is not a culture. They detect the DNA of the bacteria. Okay, which is the problem with the ALICE, that since we don't do a culture, they recommend an antibiotic, but they don't have the antibiogram to confirm that the bacteria is going to be sensible to that antibiotic. Okay, so the idea is that whenever we have an abnormal ALICE, we give antibiotics. Then after the patient finishes the antibiotics, we recommend vaginal probiotics, and then we repeat the biopsy to confirm if the bacteria is there or not. If it is there, then we give another course of antibiotics with a different antibiotic, and we repeat the whole treatment. I've got patients that have needed up to 4 biopsies until we have eliminated. What I'm doing right now is that I'm doing the endometrium culture in the first biopsy, because if I'm lucky that the bacteria that detects the ALICE also grows in the endometrium culture, I have the antibiogram. So if the antibiotic that the lab recommends is one of the antibiotics to which the bacteria is resistant, I can switch and from the very beginning be more effective. So whenever I do an EMMA analysis, I take a sample with the same biopsy and I take a sample and I put it in a conventional culture to see if something grows. The idea of giving a course of antibiotics and then giving a course of vaginal probiotics without doing the M analysis. Well, first, we don't know. We don't know if you really need it. I think that is also positive for the patients to get that information. It is not the same undergoing a treatment if you think that this could be the problem when or compared to that there is a problem and you are treating or you have treated that problem. Okay, also from the psychological perspective, makes more sense to carry out the test, confirm that there's something wrong, and treat it. Is also helpful to understand which could have been the problem in the previous negatives. So, well, if it's difficult for you to have the test done, yeah, then yes, but don't take the vaginal probiotic. First, take a course of antibiotics, a general antibiotic, wide spectrum, like amoxicillin, every 8 hours for 1 week, and then follow the vaginal probiotics. One important thing about the vaginal probiotics, they should not be mixed with the progesterone when it's taken vaginally. So ideally, what we do is that we give a course of antibiotics, and then in the cycle that the patient is getting ready for the embryo transfer, in the first phase of the of the treatment, we give the probiotics and they stop it as soon as they start the progesterone. Because if you mix probiotics and progesterone in the vagina, it's going to be a mess and you're not going to get any benefit from any of them. Okay, doxycycline is a good antibiotic, is a wide spectrum and should cover basically chlamydias, ureaplasmas, but for example, it may not be useful against streptococcus, which is one of the most common bacteria causing chronic endometritis. I would recommend doxycycline if you have been tested for chlamydia, mycoplasma, ureaplasma, and any of them is positive. These are bacteria that are much easier to test than not the chronic endometritis. As an empiric treatment, it makes sense. Taking a course of antibiotic, a course of vaginal probiotic is not going to cause any damage on your body. But if it's possible, I would recommend to do the Emma Alice because it's going to give you very useful information. It could also help understand what has happened, and it would be much more specific in order to carry out the correct treatment.
And amazing. Thank you so much, of course, for that. And as you can see, there is a thank you from the patient. And in regards to probiotics, would you recommend probiotics for before embryo transfer until birth and after?
No, no, I don't really think that they are going to be useful. I mean, if you mean vaginal probiotics, I mean, taking probiotics can be useful for other things. I'm just now focusing on the obstetrics and the gynecology. Um, we only carry out this test when we think that there is an implantation failure. We do not do endometrium biopsies in all our patients. So we must assume that in the majority of our patients, the microbiota in the endometrium is going to be okay. Okay. So in terms of improving live birth, yeah, I mean, they are useful for other things. But in terms of increasing the live birth, just taking vaginal probiotics, I don't think that is going to have any significant impact. Taking like this, and during the pregnancy, well, it's not going to harm at all, and it may help in other aspects in other parts of your body. But with regards to the obstetric, I don't think that they are going to make any change, any significant change.
And thank you once more for that, of course, as well. And let's have a look at the next question. So, working with a healthy surrogate, how likely would PGS, normal tested embryos, produce a baby with Down syndrome or other known genetic disorders? Does it ever happen?
Theoretically, it could happen because there is not a single test in medicine with 100% efficiency, but the risk is very low. With the new techniques, the NGS, basically we have a sensibility of a 99.8%. So there is a theoretically a 0.2% risk of having some kind of issue that the technique cannot detect. And the same happens with the amniocentesis. The amniocentesis is not 100% efficient. So you can even have a normal amniocentesis and very, very, very low risk that the embryo can have a problem, especially things that we call mosaicism. That means that not all the cells are affected by the genetic issue. I mean, there are Down syndromes in which only 10 or 15 or 20% of the cells have the trisomy, not 100% of the cells. And in these cases, since the number of cells that you study is limited and is much more limited in the PGS, in which you often study 4 or 5 cells than not in the amniocentesis, where you can study 25 to 50 cells. So there is a very slight difference in terms of sensitivity. But in all cases, the tests have limitations, and they could be the number of cases that I'm aware of within this new technology, the NGS, is that so far not no embryo classified as healthy has produced any issues in the baby. So we can consider that so far we have a 100% efficiency, but theoretically it could happen. But it's a very, very small amount, very, very low percentage of cases.
All right. Of course, understood. And as you can see, there was a follow-up. Yeah. So some healthy surrogates will not terminate under any circumstances, and we just wanted to make sure how confident we could be.
Exactly. Then if you do a PGS, probably that's the best you can do to reduce the risk to the maximum. That there's always going to be a residual risk in all things that we do. There is a residual risk, but it's going to be very, very, very low.
And excellent. Thank you for that reassurance indeed as well. And great thanks from the patient for you, of
You're
course,
welcome.
as well. All right, let's have a look at the next question that we have right here. Can taking aspirin when no known issues cause a problem in having a successful implantation, pregnancy, or live birth? I have had IVF once with failed implantation with good quality and tested embryo. I was advised to take aspirin. I have no known health conditions.
Well, this is one of these kind of things that first do not harm. I mean, it's true that the aspirin taken once a day, it's even recommended in cases of patients who have cardiac problems because it like thins the blood, it's a blood thinner. But my way of understanding the medicine is that if you just have a patient and you give to the patient everything that you have, the aspirin, the prednisone, the heparin, the probiotics, the antibiotics, we say in Spain, we have an expression that say that you are killing flies with cannons. And that's a bit of that, that you are using and you are over treating a huge amount of patients. I think that medicine is basically related to deciding what kind of things can be useful for that particular patient. And if not, you basically uh, become a machine that gives products without treating everybody and giving medicines to everybody without knowing if they really need them or not. This is not the medicine I like. So I would add aspirin only if I think that the patient should have got pregnant and she's not. And in that cases, in even probably or despite having a normal thrombophilias and a normal antiphospholipid syndrome, a normal folic acid, a normal homocysteine, and I may still recommend. Why? Because, for example, in thrombophilias, the thrombophilias are caused or could be caused because of mutations in the coagulation factors. And since the initial studies in the mid 90s, every so often we find a new mutation that can cause a problem. So we cannot discard that there are other mutations, yet to be known mutations, that may also cause thrombophilia and that are going to be discovered in the future. So it makes sense that even if all the tests come out normal, you may give aspirin and heparin to a patient who has a recurrent implantation failure. But to any single patient who is about to start an IVF, no, I don't recommend that.
And thank you for that once again, of course, as well. And okay, let's have a look at the next question. So, can belly fat be bad for hormone absorption during stimulation? BMI 26.7.
Well, with this BMI, I wouldn't say no. It's true that when the BMI is over 30, and especially when it's over 35, the patients may need higher doses to get the same stimulation, because obviously when you just give a shot of hormones, the volume of the body is important, and the distribution of these hormones inside of the body is also important. It is not the same to treat someone whose weight is 55 kilos whose weight is 122 kilos. The effects of the hormones are going to be different. So it's better to have a good BMI, because probably the stimulations are going to be much more effective, and the majority of the hormones are going to go to the receptors in the ovaries, and are not going to be stored in the fat all around the body.
Of course, understood perfectly. Thank you so much for this once again. And next one is, what is natural IVF? Is it not too invisible
That's
to retrieve only one or two egg every month and freeze bank them?
I don't think that it makes sense. I mean, IVF, if it makes sense, in my opinion, okay, the results with natural IVF are not that good. Understanding natural IVF, just following your cycle with a very low amount of hormones, and then going for the dominant follicle and doing the pickup of that follicle. Okay, if this is the standard concept for natural IVF. So, which are the advantages? That in some cases of patients who have a low ovarian response, and that giving them hormones are not going to make them produce many follicles, it could be useful. But does it has any advantage when compared to IUI, for example? Is very, very, very tiny, the advantage, very light. I would recommend doing IUI rather than natural IVF. The main reason is that in up to 25% of the cycles, you do not get the egg. In another 20-25% of the cycles, the egg is not of good quality, especially when you're doing natural IVF in patients over 38, 39, which, on the other hand, are the patients that most commonly have lower ovarian reserve. So natural IVF, in my opinion, makes sense only in young patients who have other factor that makes IUI useless, like a male factor, like tubes block, because if not, it is worth to work to obtain more oocytes. Um, I have a lecture about IVF in patients older than 40, and it's clear that the more eggs you have, the best the prognosis is. Taking hormones is not bad at all. As I always say, stimulations, if the stimulations were risky for women, it would be very controversial from the ethics point of view. Treat egg donors that can go through one, two, three, four, five, up to 6 rounds of IVF. So we do that because the evidence is that taking hormones is not going to cause any mid or long term effect on your body. So Phil can reassure you about the stimulations. Don't be afraid of taking injections to try, because if you, instead of one, you take 4 eggs, you are significantly increasing your chances of having a baby. So why do you have to go through 4 rounds, 4 months? Let's say that you are 41. In order to get 4 eggs, you need to invest 4 months. This time can be crucial, and the quality of the egg that you are going to get in fourth attempt could be worse than the first one. If you take a stimulation and you get those 4 eggs in a single round, you may improve your outcome. So I can see the point, and taking into account that is usually recommended in patients over 38. I prefer to give a mild stimulation or even a strong stimulation, because I know that if I get 3, 4 eggs, I'm really improving your live birth, not the pregnancy rate, your live birth compared to one by cycle.
And excellent. Once again, thank you so much. And we will go back to the question in regards to Emma analysis. Okay, so is Emma Alice test similar to hidden C test?
First time I hear that this name. So
Okay.
I'm afraid that I can help you. Probably there could be other tests. I know that in France there's a different test that checks the same, and probably there are going to be more and more. Emma checks for the microbiota. Alice checks for bacteria in the endometrium. If the hiding C does the same, it is the same.
And of course, that makes perfect sense. Thank you so much for that. And let's have a look. Next question in regards to the vitamin D. Okay, so in your opinion, how much vitamin D should be given in before and during pregnancy? What is your view regarding good quality fish oils, example calciums and organic folates and
Mm.
prenatals?
Vitamin D depends on the levels. If the levels are below 20, you should treat with high doses. And high doses, I've got patients that I've treated with 50,000 units per week. So that means more than 7,500 units every day. Okay, because I wanted them to recover very soon. But these doses are contraindicated during pregnancy. In pregnancy, the vitamin D is the only one who, if you take too much, they could have a toxic effect. So you have to be very careful. I mean, you can take thousands of vitamin C, thousands of vitamin E, vitamin B, B12, and nothing is going to happen. Nothing wrong is going to happen. But too much vitamin D can be harmful for you. So during pregnancy, the maximum recommended dose is 600 units per day. So we usually treat patients with that when we need to restore the or recover the vitamin D levels. We treat with 25,000 units per week. There are like small bottles here. At least we do have them here in Spain. You take the bottle once a week is an oil, and then you have enough vitamin D for 1 week. So it's a very easy treatment. And in cases of severe deficiencies, I give 2 bottles of 25,000 units. So that's a maximum. Fish oils, calzones, folate, and everything. Well, these kind of things, honestly, in terms of improving light birth, no evidence at all. No evidence at all. I prepared a lecture about diet and IVF outcomes, and then all the studies confirm that these kind of things do not improve the quality of the egg, which is the main factor related to better live birth. But in any case, they are all going to help you start the pregnancy in a better condition. And that's also important. So we do recommend to have a good diet. We do recommend taking different vitamins, coenzyme Q10, DHA, omega 3, omega 6, folate, and all these kind of things. Because in all cases, if we are successful, you are going to be pregnant. And we prefer to look into the future and not focus on being successful and forget what happens afterwards. No, we want to go ahead. Coronas contains vitamin. Uh, well, the sun and the vitamin D. You know that if you are exposed to 15 minutes of sun, 15 minutes, your body has produced all the vitamin D that the sun can trigger in your body. So even in if you live in Scandinavia, it could be very very easy to be exposed to the sun 15 minutes a day. So there is a kind of a legend that here in Spain we don't have deficiencies of vitamin D, and believe me that the majority of the patients have low vitamin D levels. Uh, well, I would say that if your levels are okay, you don't need to take 1,000. It's not an issue, as long as the levels in blood are not very high. But probably if you took 600 units, that should be more than enough. If your vitamin D levels are low, depending on how low they are, this may not be enough.
And wonderful. Thank you so much, of course, once again
Mm.
for the answering the question and of course the follow-up as well. Next one is, what is the name of the blood test that can check the genetics of the baby during pregnancy?
Well, there are two types. There are the non-invasive prenatal tests, which are the tests that are usually done on week 10, and that consist on taking some blood from the mother, isolating the DNA of the baby, and then you can do a limited amount of genetic testings of them. And then you have the CBS, which is an invasive test in which you take cells out of the placenta. It is usually done around week 11, 12. And then you have the amniocentesis. I've said that there were two, there were three. which is the standard test that is done around week 15. And you basically put a needle into the sac and you obtain amniotic fluid and you study the cells that are floating. The most efficient probably are the amniocentesis because you are testing cells from the baby. Then the CVS because you are testing cells of the placenta, though it is known that there are some genetic abnormalities that are limited to the placenta and the baby may not have them. And the less efficient in terms of results is the non-invasive, but it has the advantage that it's non-invasive, so it means zero risk for you. Okay, the other ones are invasive and they may cause a miscarriage. The risk is between 0.51%, is not very high, depending on the hands who performs the test or the expertise of the doctor, but they are invasive and they have risks. So you have to decide which one suits your case.
And thank you. There is a follow up. Okay, so let me go straight to that one. So does the CVS carry the same risk as amniocentesis?
Yeah, very similar. As long as the person who performs the CVS has the same expertise that the one who performs the amniocentesis, you should expect to have that 0.51% of miscarriages.
And wonderful. Thank you for this once more again. And the next question is up. I'm waiting for my second frozen embryo transfer. I have one fresh embryo transfer, very good embryo, extended blastocyst. I have regular ovulation. My endometrium in time of ovulation is usually fairly thin. In what cycle do you recommend to perform my next frozen embryo transfer? Natural cycle, moderate, natural cycle, or stimulated cycle, and why? Thank you.
Well, are you sure that it was a good embryo? Because, as I've said, having the problem is that in some cases patients or even doctors tend to think that transferring a pretty embryo means that the embryo is a good embryo, and that's not always true, especially as you get older. So having an expanded blastocyst, if you are 42, the chances of that blastocyst to be genetically normal are 11%. So 1 out of 10 are going to be really good embryos. If you are 32, more than 70% of these embryos are going to be genetically normal. And then there would be a really strong correlation between morphology and genetics. In any case, I would say that an endometrium of 7 millimeters, it is normal. There is a Last year there was a very big revision about the concept of thin endometrium carried out by the Canadian Fertility Society, and they concluded that as long as your endometrium is around 7 millimeters, that's that's fine. In an IVF, that means that you've been stimulated. Our cutoff point is 6 millimeters when we do embryo transfer. So, uh, to me, your endometrium is absolutely normal. So probably the thing has more to do with the fact of using hormones or using natural cycle, but not because you're going to get a thicker or thinner endometrium. It's probably more related to the fact of how good that endometrium is going to be from the functional perspective. Well, if you have tried hormones and it does not work, try to change to a natural cycle. We do use some stimulated cycles in some cases of patients with really thin endometriums. Thin endometriums mean endometriums that are between 4 and 5 millimeters. Okay, because we try to stimulate and see if we stress or we give higher doses of estradiol. But in some cases, working with pills does not work, and the endometriums respond to the natural estradiol. So in these cases, we use stimulated cycles. But we usually work with hormone replacement therapies or completely natural cycle. The only thing that we do is that we trigger the ovulation to schedule the embryo transfer. But as I've said, 7 millimeters is not that bad. For us, it would be okay.
All right, of course. Thank you so much. And there is actually another question from the very same patient. Okay, so let me again
Mhm.
go straight to that one. So my first gynecologist saw an ultrasound scan that position of my uterus fundus is a little bit lower than recommended, and she refused to do hysteroscopy. My second gynecologist saw an ultrasound scan, cat's eyes, and she is sure that I have septum or mild form of heart shape uterus. Would you recommend hysteroscopy or not? I already had once unsuccessful fresh embryo transfer.
Well, the thing is that nowadays, if you can have a good 3D scan, that should be more than enough. And because the hysteroscopy is only going to let you see the shape of the cavity. But if you have this kind of heart-shaped uterus, it could be because you have a septum or because you have a bicornuate uterus. That means that the uterus, the whole uterus, have this kind of shape. You may have a normal uterus with a septum, or you may have a bicornuate. And if you just see the inside of the cavity, you are not going to know if the external part is normal or not. So in this case, a good 3D scan can help. And in some cases, a magnetic resonance and an MRI, magnetic resonance imaging, can also help to get a better uh, sh- idea of the external shape of the uterus. But of course, in this case, for example, you see that there is something wrong on the scan. It could make sense to do a hysteroscopy because you've seen something wrong. I think that there are other tests probably not so invasive and easier than the hysteroscopy, like a 3D scan or a MRI. But hysteroscopy could help you to get a direct view of the cavity and confirm whether you have this kind of hair-shaped uterus or not.
And thank you so much. And actually, there is a follow up from like two questions before we had, okay, in regards to the test. So, what was the name of the first test at
Ah,
10 weeks?
there are a lot of names for the test. In Spain, we have like 7 different test names. But that's usually called an non-invasive prenatal test. Okay, because basically it consists on, as I've said, picking up blood from the mother and then isolating the DNA. So it's not invasive as the CBS or at the amniocentesis because you don't have to put any needle. Well, you need to put a needle to get the blood, but not inside of the uterus like in the other test. So it's completely free of risk.
Okay, wonderful. Thank you for that clarification as well. And let's have a look at the next question that we have. So, what is your view in what the surrogate should do that would be a bit different to a mother carrying her own or her donor's egg in a pregnancy to ensure a healthy birth of baby?
The main problem, I would say that there should not be any difference at all. The main problem is the surrogacy is illegal in Spain. So my experience in this field is zero because we can't do that here, no? But I've got some patients that have gone through surrogacy. They fly to other countries to have this treatment, and I don't think that they should be do anything different. I mean, they should have a life as healthy as possible, and probably the best advice I could say is just to do what you would do if the baby was yours. So that means that continue with a healthy life, doing some sport, all the things that you would recommend to to any, and in this case the quality of the egg or the whose eggs are you using, it does not make any difference. I mean, because once she's pregnant, how the body is going to react to this pregnancy is going to be exactly the same. So if she's a surrogate and has gone through IVF with her own eggs, or you have used another eggs coming from an egg donor and transfer the embryos to that surrogate, I think that how they should behave during pregnancy is exactly the same.
And thank you once again, Chris, for this. And let's have a look, okay? Different topic this time. So, that progesterone level effect on the implantation. Do you recommend progesterone injection on top of the pessaries?
Well, that's a quite interesting thing because it's now becoming trendy, I would say. Well, we did a study in which we tested 255 patients, and we were checking the levels of the progesterone on the day of the embryo transfer. Okay, patients undergoing hormone replacement therapies. Okay, because there were another study that suggested that if on the day of the embryo transfer your progesterone levels were below 9.2, there could be a lower implantation rate and a higher miscarriage rate. And in those cases, it was suggested that adding injected progesterone, but not intramuscular, subcutaneous progesterone, could revert this effect. And the results with that in those cases were promising. The thing is that the the incidence of these low levels are very different when you compare different clinics. For example, and I can tell you about two clinics that work here in Barcelona, our clinic and Clinic de Cheus. They have published a result and a study in which they have tested progesterone, and 30% of their patients had low levels of progesterone. That's incredible because in our group of 250, only 9% of the patients had low levels of progesterone. Which is the difference? Well, probably they work with different protocol of progesterone and they use 400 milligrams every 12 hours, and we work with 200 milligrams every 8 hours. So we may probably get steadier levels of progesterone throughout all the day, and they may have peaks in the morning and in the evening. And when you test the progesterone, which is usually on the midday when most of the transfers are done, you may have an abnormally low levels. But our experience that is that if you give some cutaneous progesterone, subcutaneous progesterone, when the levels are below 10, I would say 9.5, 10, the outcome is going to be better. And you are going to rescue cases that otherwise would have been negatives. I don't know if because of a lack of implantation or because an early miscarriage, because the levels are not good enough to let the embryo going on. But in any case, is useful. Another issue that we have is that the cutoff levels are different. There are clinics that suggest 10.4. There are other clinics that initially considered 9.2 and now they have recommended 8.7. We work with 10, so it's a bit of a mess, you know. But in these cases, what I recommend is that the clinic should test their patients to know exactly how often that happens in their population and according to their own protocols, and then um, determine this cutoff point and decide when subcutaneous progesterone should be added to the vaginal pessaries.
Amazing. Thank you so much once more for explaining this one as well. Let's have a look at the next one. Okay, should the progesterone level be checked and monitored after the embryo transfer? How much is a normal level on transfer, and how much should increase
Hmm.
1 week post transfer? How much is normal level? Better to have higher level than lower.
Well, the idea is that progesterone in excess is never an issue. Okay, so if you have to choose, it's better always to have higher levels. But once more, the main problem is that the cutoff point is still controversial. As I've said, clinics consider that close to 9, other ones 10, other ones 10.4. So basically, you should check which are the levels that in your clinic lead to a significantly lower pregnancy rate, and then correct that. Correct that. I don't think that probably the population that the different clinics are treating are different. Also, the ethnics or the age of the patient. So, uh, if you want to check the progesterone levels, they should be checked on the day of the embryo transfer. And in all cases, as always, except in a very specific, sorry about that, because I now have a case of a patient that had normal levels on the day of the embryo transfer, and 6 days later, the levels were extremely low. But this is probably the first case that I've had after doing a lot of research, but it could happen. This is medicine. Welcome to the unexpected. So I would say check your levels on the day of the embryo transfer. If they are good, you should not modify the treatment. If they are low, according to what your clinic considers low levels, then add one subcutaneous progesterone a day, and that should be more than enough to recover the normal pregnancy rates.
Wonderful. Thank you once more. Next question is so about the natural cycle. You have mentioned this before, but would you recommend a natural IVF cycle for women over 40?
Only in very specific cases. In very specific cases, because the chances of doing the whole cycle and losing 1 month for nothing are probably up to 50%. If you just take into account the cases in which you do not get the egg and the cases in which the egg has not the quality to be fertilized. So for me, it's a very low. So I would prefer to treat even with now there are treatments drugs that are very comfortable that you take one shot and they stimulate you for 7 days. So why do you want to go through 3 4 rounds of cycles in which you have low chances of getting an egg? It's better to just go through one round and produce 2 3 follicles, 2 3 eggs. That's for me is better. So only in very very specific cases would be advisable, especially over 40. I mean, if you're younger, well, but over 40,
Of course. Thank you so much for the clarification once more. And is using intralipid increase implantation?
no evidence. As I've said in my slide, the American Society considers that the evidence is very low quality, not strong at all. Intralipids had also may have important side effects. They contain soja. It's very allergenic. There has been described really severe side effects in patients. Some of them needn't even been admitted at the hospital. So it's not like you're taking something that is not going to cause any problem. So in my opinion, the effects have not been proved at all. And taking into account that the benefits do not outweigh the risk, I do not recommend them, and we never do them.
All right, once more. Okay, thank you for that. Next question again, a shorter one. My TSH is on the low side, 0.18. Can that also have a negative effect on implantation?
It depends, because if it's because you are on a treatment and the thyroxine is keeping you this level so low, no. The TSH is the hormone that stimulates the thyroid to produce thyroxine. So if it's low, it could be because your thyroxine levels, or it's usually because your thyroxine levels are high. If this is caused because the treatment is because of the treatment with the hormones, no problem. Usually, endocrinologists prefer to have the patients in the hyperthyroidism than not in the hypothyroidism. It's better to have a light excess of thyroxine. If you are not having any kind of treatment, well, you may have a hyperthyroidism, and this is why your TSH is low. Then you would have to go to the doctor and see if this is something that no medication. 17, 18. Oh, that's Picomol. My God. Yeah, because we work with different doses. But that should be 1.6. Is on the edge. It could be that you are slightly hyperthyroid. You have a slightly hyperthyroidism, but this kind of problem is not going to have an impact in the implantation. It's usually always no. Usually no. It's always worse to have high TSH than low TSH. So, well, and probably if you go to the endocrinologist, he's not going to give you anything. He's going to say, okay, go ahead, and then if it gets worse during the pregnancy, we would treat it. But no, I wouldn't be worried about that.
All right. Again, thank you so much for that. Let's have a look. Of course, there are more questions that we have. Okay. So let's have a look at the next one. So during a short protocol, I had 7 follicles and only 3 eggs retrieved. It has been recommended to try long protocol to increase follicle synchronization with suprafact for 7 days prior to period start date. I have heard of varying lengths of the down regulation treatment. Is this dependent on the type of medication, or does this seem short?
No, no, that's the standard long protocol. And if there were only, I mean, when you retrieve these eggs, it could be because the size of the follicles were really different. And in this case, it makes sense to work with the long protocol. And the standard is to start any drug that you use, suprafag, gonapeptyl, decapeptyl, like 1 week before you have your period. That's the standard protocol. I wouldn't recommend down regulating for longer than that, because these drugs may also reduce the response afterwards. So you should stick to the days that we recommend, which is 7 days, and try to use the lower possible dose of the suprafact. One thing that we do is that we start with stronger dose to cause the down regulation, and as soon as the patient starts stimulation, we will reduce the dose of the suprafact to avoid this negative effect on the ovaries. So this is a standard lung protocol, and if you've only got 3x because the follicles were too big and too small, lung protocols make sense.
And wonderful. Thank you so much once more. And of course, there is a follow up. Okay, let me go straight to that one. What is the lower dose of superfat
Half the
choice?
dose that you were recommend. Sorry,
Mhm.
Caroline.
Sure, no
I know.
problem.
The idea is that if you start with the suprafag, whatever dose you recommend, then it's better. What we do is that we reduce the dose to the half once, because one thing is when we're trying to down regulate the patient, and another thing is when we try to keep the patient down regulated. So if we work with, no, I don't know, Procrene zero point 0.1, we go down to 0.05. If suprafag, if I'm not wrong, is like zero, because suprafag is not available in Spain, so I'm not very familiar with it. But I think that is the dose is zero point 0.5, then you should go to 0.25 whenever you start the stimulation.
And once more, thank you for that clarification, then, of course. And there is a thank you from Karen for you as well. And let's have a look. Of course, there are like some questions left. Let's have a look at the next one. I have had several good embryos but fate transfers. I do not smoke. I have lost 12 pounds. My diet is good.
Mm.
Removed gluten. We can't figure out why. My physician is not familiar with Emma or Alice. What advice would you have for me?
How old are you?
Yes, exactly. If you can write
You
that
know, I mean, because if you are 35, probably I would focus more on the endometrium. But if you are
44.
41, huh?
Yep. 44.
44, and
Yep.
you are using your eggs, then if you are using your eggs at 44, I'm absolutely sure that unfortunately the main problem is the genetics of your embryos. What I would suggest in your case, since you are lucky enough to produce a good number of embryos, is consider PGS and check the genetics of the embryos before transferring them. At 44, statistically, only 1% of the embryos are going to be genetically normal.
All right.
So
Sorry,
first,
there is a follow up here. So embryos have been normal with PGS.
okay. Well, then there are two different things that may impact in your case. One thing is that though the genetics is the most important thing that age affects, because it's related to increased risk of genetic abnormalities, the age may also affect other parts of the egg that also play relevant roles in the early stages of the embryo development, like, for example, the mitochondria, which are the structures that produce the energy that the embryo needs to uh, continue dividing. And in some cases, one of the things that we have observed is that when we do PGS, the implantation rates remain very similar until the patients are 43. And when they are older than 43, though the results of the genetically normal embryos tend to be better, they are not as good as when the patients are 41, 42, or 43. And we think that this is because these other structures may be also too old. And if the mitochondria fail to produce the energy that the embryo needs, this may cause a failure in an embryo that is genetically normal. So that could be one specific factor that unfortunately cannot be tested. This is just a theory. And of course, there could be other factors related to your uterus, like having a normal microbiome, or having thrombophilias, or having antiphospholipid syndrome that should be tested. Because if you are transferring genetically normal embryos at your age, you are transferring the best embryos that you can produce. If these embryos do not work, is because either they have other problems that we are not going to be able to solve, mitochondrial issues, or there could be something wrong on your side. Aspirin, heparin. Well, we have not discussed about the doses of heparin, depending on which context. There are cases I mean, the standard protocol with heparin is 40 milligrams a day, or 4,000 units of enoxaparin. But I've got patients that have needed up to 100 milligrams, huge amount of heparin, to have an ongoing pregnancy. Um, but of course, hemolysis would make sense in your case, because that's one of the tests that would let us know if there is anything wrong on your size. Checking thrombophilias to decide if you need higher doses of heparin, it could be also another good thing. Um, and that's it. Probably not done. Yes, 40. Well, I've got cases, but these are cases in which probably mostly related to recurrent miscarriages, in which I've increased the dose to 60. It's becoming mm, also much more and more common to work with 60 milligrams, seemingly 40 milligrams in cases in which or in cases of patients who really need heparin may not be enough, and there is kind of a trend of but 60 milligrams is a strong doses that should be monitored by hematologists, not by gynecologists.
And of course, thank you so much once more for your thorough answer to that one. And of course, there's a thanks from the patient for you as well. And let's have a look at the next question that we do have right here. I'm sorry, it's right here. I have had four failed ICSIs with two biochemical pregnancy and one missed abortion. I am 40. No PGTA was ever done so far. What would be your next steps?
Well, you're already given the answer, considering PGTA, which is the same of PGS. Yes, because the first thing that we need, I mean, our current approach in cases like this is we first need to be sure whether the embryos are of good quality or not. How are we going to, before deciding to start changing things? Then we do an IVF, we check the genetics. If the results of the genetics suggest that the genetics are not the problem, because most of the embryos are genetically normal, then before transferring these embryos, we consider carrying out other tests to discard problems on your side. But if we check and we study 8 embryos and only one is abnormal, sorry, only one is normal, probably the main problem that you've had so far is the genetics of the embryo. So I don't think that you could also have something wrong at the endometrium or in your body. It would make sense to transfer this embryo. So the PGS or the PGTA somehow is going to help us know if these embryos, apart from being pretty or morphologically good, were also genetically normal. And based on the results that we get from the PGS, we can then decide to carry out further studies on your side or not.
Wonderful. Thank you so much for that. And let's have a look at the next one. So we've just experienced our first IVF ICSI cycle with a 5AA grade hatching blastocyst. We are both just 30. Is it likely that it fell due to equality? And should we be aware of any changes to our protocol for when we commence frozen embryo transfer?
I really think that you've been unlucky. That's basically, and always when I say that is that basically admit that I don't know what has failed. But even in cases like this, in which of course I don't know what you've been through IVF if you are 30 years old, okay, because that could be also something severe. Because at 30 you should not have any problem getting pregnant. 5.6 is a slightly high, but I don't think. Well, that's high. I mean, it's higher than 4.4. And if there is anything that everybody agrees is that having a TSH over 4.4, male morphology issue. Okay. Well, if there is a male factor, I don't think that the egg is going to play any role. Of course, this TSH is really high. Uh, it could have made things more difficult for the embryo. But even if we transfer the best possible embryo in the best possible environment, we are never going to get 100%. So I would probably consider transferring another embryo before starting to start to carrying out tests on your side to see if there is anything wrong. Of course, correct the TSH, that for sure, and correct any other easy thing that you may have. Well, as I've said, BMI, weight. No, 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 not at all. No. I would recommend stick to one blastocyst, not transferring more. I mean, if you transfer more embryos, the pregnancy rate of the transfer is going to be higher. But the embryos are individuals. They do not affect each other. They do not help. They do not disturb. So if you transfer one, the implantation rate is going to be the same that if you transfer two. If you have several embryos, I would still recommend transferring one in your next attempt. And as I've said, without considering any investigation at this level. Even when we do egg donation, we do not have a 100%. With one good blastocyst, you should expect to have a 65% chances. So there's still a 35% of the patients who are not going to get pregnant. And this does not mean that there's anything wrong or that there is any problem that should be treated. So I would just move forward and consider a second transfer. And if that second transfer fails, then yes, then I would consider doing some research to see if there is anything that should be or treated or fixes or tweak.
Amazing. Thank you so much once again for, of course, that thorough advice. And there are a few questions left. We will be slowly finishing. Let's have a look at the next one. So 41, and explained infertility, 5 miscarriages in 18 months, IVF 3-day, 5-6 euploid embryos out of 7 that fertilized. First IVF failed. Is there hope for last 2 working? What else should be tested or done?
Okay, just let me check one thing. 5 miscarriages, natural in 18 months. IBF, 3-day 6 euploid embryos out of the 7 that fertilized. Okay, so I understand. So you had 7 embryos and 3 were tested and genetically normal. Yes, yes. Okay, but probably these are one of these cases in which you've been so lucky having 3 embryos out of 7 that probably would be a good idea to not wait too long to consider at least some easy tests like thrombophilias, antiphospholipid syndrome, and things like that to discard any issue because these embryos are very, very valuable, and it's going to be hard for you, or it could be hard for you to have so many. So in these cases, before moving forward, you can do some easy or research. And of course, as I've said, even if we transfer the best embryo, there is no reason to think. What I would suggest in your case, since you've been pregnant 5 times naturally, is that if whenever you want to transfer the frozen, use the natural cycle. Okay, you've been tested. Then I would consider move forward. But probably in your case, rather than using hormones and work with an hormone replacement therapy, I would recommend using a natural cycle. Using the natural cycle, you've been pregnant 5 times. So why do you want to try something different? Now that you are transferring good embryos, try to work with the natural cycle. And in your case, probably because these miscarriages could have been due to some yet to be known issue, I would also consider aspirin and heparin despite having normal thrombophilia and normal antiphospholipids.
And thank you for this one as well, of course. Okay, last embryo miscarried was chromosomally, sorry, normal.
Yes, because unfortunately there are other factors that may also cause a miscarriage and are not genetics, like abnormal development, abnormal implantation. We know that when we transfer an embryo that is genetically normal, uh, there is still some chances, some problems that could happen. And we are reducing the risk of miscarriage by a 70%, but there is still a 30% of cases in which you may have another problem, and some of them are isolated. So, but because of that, and because of the information you have given to me before, I would recommend to consider heparin and aspirin. Aspirin started 1 month before the embryo transfer, and heparin started on the first day of the cycle in which you are starting the preparation for the embryo transfer. So do not start it on the day of the embryo transfer, but a couple of weeks before.
All right, sorry. Something additional. I
You took
took it. So.
Lexen as well
Mhm.
in the IBF, but in the IBF or when you had the first embryo transfer. Because if you took it in the IBF but you didn't take it when you transfer, and the frozen embryo transfer as well, then continue. As I've said, there is not 100%. So you have good embryos, they are genetically normal. You have done a basic research. If you want to get slightly deeper, well, then you can consider the endometrium biopsy to check the. I don't know if these miscarriages that you've had were complete natural miscarriages or you had some DNCs after them to clean the uterus. If you've had DNCs, these are interventions that may have changed the microbiome. All natural. Okay, I've seen on the right side now. All natural. Well, you can still consider checking if there is anything wrong on the endometrium. But the problem that you've had so far was not an implantation problem. You've been pregnant 5 times. So I would say that if you keep transferring embryos, you're going to get pregnant, and this may go ahead successfully. It's not an easy case. I have to admit that, because when someone is having miscarriages and you are covering Clexane, aspirin, and the genetics, there's very little else that we can do. Very, very few things. The endometrium, checking the microbiome, but not that much.
Of course. And still, thank you so much for your advice and, of course, for your question, indeed, as well. And let's have a look, okay, at the next question, a bit of a longer question. So I'm 44, had a couple of failed IVF with my own eggs, never ended as a positive test, used different protocols. I had my first donor egg transfer last month, also failed with 5AA embryo. A year ago, HCG short block tubes, doctor said have hydrosalpinx and to remove tubes 2 months after I had high cozy done to double check and tubes were patent hydrosalpinx not seen. I took anyway a course of doxycycline 2 weeks. Do you recommend still to do an EMA analysis or to check the tubes again?
Well, what I recommend in cases like yours is that after the doxycycline, you should take some vaginal probiotics. I don't know if you did that, because the doxycycline, the antibiotics kill the good and the bad cells. They also kill lactobacilli. So it's useful to just use the vaginal probiotics to restore, to recover the normal flora of the oral probiotics. I'm not really fond of oral probiotics. I prefer vaginal probiotics, because the vagina is close to the uterus, so whatever you put there is easier to get to the endometrium. There is not a single study using oral probiotics that has proved to even recover the vaginal microbiome. So the endometrium is much more difficult. So I would recommend to use vaginal probiotics. But can you just show me the question again, Caroline? Exactly. In any case, Emma Alice, despite taking the antibiotics, could make sense. As I've said, there are cases in which patients have needed up to 2, 3, or even 4 biopsies until we have been able to completely clean the endometrium of bacteria. So the doxycycline may have been useful or not, depending on the bacteria that you have. And the Emma Alice are also going to help see if you had the hydrosalpinx, if this had somehow affected the endometrium, because if there is anything wrong at that level, probably you may have a dysbiosis, or you may still have any kind of chronic inflammation. So I would recommend that. And that said, you have only, unfortunately, and forgive me for that, but you only had one good embryo so far, transfer so far. The last one being 44, the IVF should not be taken into account, because the genetic quality of those embryos, it has probably been very poor. So you have only had one good embryo transfer. So probably if you have more, what I would suggest before considering Emma Alice is to go for another round. And if after 2 you've not got pregnant, then consider that. Consider the Emma Alice.
And again, thank you so much. Excellent. Thank you for this. And we will be, as I mentioned, slowly finishing. There are like few questions left, so I guess we can still finish them, right, Dr. Raul?
Yeah, yeah, yeah.
Okay, perfect. Thank you. Just checking in. And let's have a look at the question from Karen. So, I had natural ectopic pregnancy in right tube treated without surgery or medication. Some months later, I had high COSI where the liquid passed through the tubes without requiring additional pressure. However, could not be seen in the right tube. I've heard the liquid in high COSI isn't suitable to check for clear tubes and that HCG should be done. Would the Emma Alice test be more useful or should I do both? Does this still matter if going for IVF rather than trying naturally?
No, the HICOSI is helpful. It's a scan that also allows in an easier way to check for clear tubes. I don't think that HSG is going to improve as long as the doctor who performs the HICOSI has a good expertise. The results are very similar. So you may have an ectopic pregnancy and still have a patent tube. That's something that could happen. But in any case, what I can tell you is that that tube is not going to work fine. One of the main problems that we sometimes have is that we can only diagnose a tubal factor when there is an anatomic abnormality, but the tubes are not passive structures, they are active. They transport the embryo using kind of a contractions. And in some cases, they may not work as expected and behave as if there was a real tubal factor that cannot be diagnosed. If the tube was not damaged before the ectopic pregnancy, it is now damaged. So I wouldn't be confident on this tube. And with regards to the result, I mean, the MRIs check something different, change the environment in the endometrium, but they do not check if the tubes are patent or not. They may help if you think that these tubes have been damaged by an infection or an inflammatory process, because this inflammation may also be in the endometrium. But if the tube have been damaged, for example, because of an endometriosis, the EMA ALIs are not going to shed any light into your problem. So I would consider them only if you think that the tube was damaged because of for because of an infection. If you are going to do IVF, well, no, I would say that probably if the IVF is the right treatment when you think that there is a tubal factor. So I don't think that you should do any MRIs at this stage. Just do the IVF, check the embryos, transfer them, and if you don't succeed, then consider any treatment as if you had on or a recurrent implantation failure. But at this stage, if you are going to try, even if you are trying to conceive naturally, I don't think that MRIs makes any sense if you think that this tubal problem is not caused by infections or inflammations.
And perfect. Thank you once more okay, for that other one as well. And again, there is a thank you for your very helpful answer.
Welcome.
And let's have a look. Okay, next question is from Kevin. Sorry, let me go straight to that one. So we have had one unsuccessful donor egg transfer and have two frozen embryos left to transfer. Is there any benefit to transferring both at the same time, or would the best route to be to transfer one at a time and have two further attempts? My wife is forcing.
Okay, so there are two different concepts that sometimes are misunderstanding: the pregnancy rate per cycle and the pregnancy rate per transfer. Okay, the pregnancy rate per cycle means the chances that you get pregnant with any of the embryos that you have created in after a single retrieval or after a single egg donation, after a single cycle. Okay, let's say that you have three embryos. These embryos should offer you a, let's say, 80% chances of getting pregnant, either with the first, the second, or the third. Okay, this 80% is going to be achieved exactly the same if you transfer three times one embryo or if you transfer all three together. So transferring embryos together do not increase the overall pregnancy rate of the cycle. It just shortens the number of attempts that you need, and this may mean fewer attempts, fewer money, but in terms of results, it is exactly the same to transfer three embryos together or one by one. The main problem is that if you transfer three together, you may have a triplets, which is a bad outcome. This is why I always tell my patients that there is no medical reason for transferring more than one embryo at a time, because it's not going to improve the performance of the cycle. But if you transfer two embryos, you may be increasing the chances of the embryo transfer. When this does make sense, when the risk of twins is not that high, because it could be very um, demanding, psychological and emotional demanding for the couples. Let's say that you had seven embryos to go for 7 rounds of 7 transfers with 7 negatives. Apart from the money, psychologically, emotionally, could be devastating for you. So your wife is 40. It's true that the risk of having twins at this age is not that high. So considering transfer two is a good idea. Okay, but not because this is going to improve the pregnancy, the live birth of your cycle, just because it's going to shorten the number of attempts that you need.
All right, again, thank you so much for that one.
Mm.
And let's have a look at the next question. Okay, what is your all else has failed plan for patients age 40 with their own euploid embryos?
Well, I don't consider that a scenario. If- I think that if we have a good number of euploid embryos and patients over 40, the success rate should be really good. But of course, there are other aspects or things that we can do. We can do. As I've said, I've explained quite a few today. I mean, checking endometrium, checking blood tests, thrombophilias, and of course, whenever everything else has failed and you think that you've done your best and the patient continues with negative despite transferring the best embryos that you can transfer or that you can get, the only option is surrogacy, because I can't change your eggs, I can't change the sperm, but I can change your uterus. I mean, at least in Spain.
All right. Thank you once again, of course, for that. And as you know and see, and there is things from the previous patient for you. And sorry, let's have a look at the next question. So I'm 48 without menstruation since September. I just started to take progesterone after my gynecologist suggestion and hope my menstruation will come back. My MH is at the moment 0.28. Do you think if I can get pregnant during the 3 months of treatment, I should try IVF with my own eggs?
I don't think so. The main problem that you have, I mean, most of the time when we do recommend egg donation, it is not that the patient cannot get pregnant. It is because we think that the IVF is not going to add any benefit to the chances, or any improvement to the chances that you may get trying to get pregnant on your own. So with this low AMH, probably if you go through any stimulation, you're going to produce one follicle. If this is what you already produce in your cycle. So at 48, your chances, and I'm just talking about chances of having a baby, okay? Your chances are going to be, in the best scenario, 1%. If you go through an IVF with this AMH, your chances are going to be 1.5. So it is absolutely worthless to go through this process to just improve your chances by a zero point 0.5 or a 1%. It does not make sense, and it does not make any sense at all if you can't get pregnant on your own. Another scenario would be if you were a single woman with no partner and your only option then was the IVF. But if you have a partner and everything else is normal, the main problem is that IVF with this AMH is not going to improve at all the chances that you have. So if you want to get pregnant with your eggs, just my recommendation would be keep trying naturally, and whenever you want to do a treatment, consider egg donation. But do not consider IVF. It's going to be a waste of time, money, and and emotions.
And again, thank you so much for that clarification. There are like four questions left, and we will be slowly, and we will be finishing. And of course, there is a thanks from the patient for you. And this one is up. What made the injection subcutaneous better than muscle injection for progesterone?
The side effects. And muscle injections, apart that muscle injections are painful because it's an oily solution, the subcutaneous is a water solution. There has been described severe side effects from intramuscular progesterone, some of them really severe, like pneumonias, eosinophilic pneumonias, apart from local abscess and problems with the injections. While the subcutaneous can be self-administered, you need a nurse to take in muscular injections. Subcutaneous can be self-administered like any other drug during the IVF, and the effect is exactly the same. So I can see the point of using intramuscular progesterone nowadays if you have subcutaneous available.
And again, thanks so much for this. And let's have a look. Next question is again straightforward. What's the measurement unit you're using in Spain for progesterone?
Nanograms per milliliter.
All right. Thank you. Next one is right here. So does Levonox work in the same way as heparin?
Is a brand. Levenox is a brand. Heparin is the generic name.
All
Is
right.
it?
Thank you. And I believe this is our final question then for tonight. So, what about mild form of adenomyosis in backside of uterus? Is this a big real problem for implantation and for further pregnancy? I'm very worried about that.
Adenomyosis is one of these kind of things that is also very controversial. When you really see adenomyosis in the scan and you see all the typical signs of the endometrium going inside of the uterus, the big cyst, the hyperechogenic myometrium, the asymmetry of the uterus, in these cases, it may make sense to downregulate patients before transferring the embryos, because in these cases it has been suggested, I mean the data are still controversial, but it has been suggested that the implantation rates can be lower. Okay, so if you really have adenomyosis and it has been easy to diagnose this in a scan, then if you are going to transfer embryos, consider down regulation before, not a really long down regulation. I mean, just that being down regulated from the cycle before. In cases of severe adenomyosis, I remember one case that I had. I down regulated the patient for 3 months because the uterus was really uh, awful in terms of all the things that she had, but that's very specific cases. Usually down regulated from the prior month is enough to keep this pseudo endometriosis at a low level, and then it is believed that it may improve. At least it's not going to cause any damage, and in cases of adenomyosis may make sense.
And as always, amazing. Thank you so much for that. As I mentioned, that was our final question for today. And it's been a long session, but definitely interesting. Lots and lots of questions. And also, I want to thank everyone for staying up with us here tonight as well. And also for your patience, because I know some of you had to wait a bit longer for your question to be answered. So,
Mm.
definitely, it's been a brilliant session. And of course, Dr. Raul, as always, you've been excellent. And thank you so
Thank
much for
you.
this. I will send you a link right now. Of course, you can use that if you would like to get in touch with Dr. Raul and his team to get some more details as well, as
Very
always.
good.
And of course, as you can see, Dr. Raul, there are many things coming up your way. Thank you for
Thank
your
you.
time to answer all my questions. And there are thank yous.
I knew I was going to be into trouble because of the many different topics I was talking, that would lead to many different questions of very different type.
Exactly,
Okay,
but
so
we don't mind at all.
no,
We
no,
don't
no,
mind
no.
at all,
As
and
long as everything is clear enough.
I do believe so. And as you can see, wonderful presentation, very helpful answers. And
Thank
yes,
you.
so thank you indeed for your time as well, because it's been over 2 hours that we are here. So thank you so much for this. And there are non-stop coming up some
Mm.
comments. So thank you. I do hope we
Okay.
will have another session pretty much soon with you. It's always a great pleasure to have you back with us. So thanks for that.
Thank you to you for inviting me.
Thank you. And to remember, it has been recorded. So if anyone has missed any parts of this, well, you will be able to find it on myivfnsense.com and, of course, on our YouTube channel. So, and I do hope to see you back here tomorrow. Have a lovely evening or day. And Dr. Raul, thank you for your time once again. And,
You're very
well,
welcome.
till our next event. Okay?
Perfect.
Perfect. Thank you so much. Take care.
Bye bye. Take
Bye.
care.